So, Michael, I had actually, when it was broached to me, to speak about the state-of-the-art of radiotherapy in the management of treating localized prostate cancer, but given the pathology conference here, I wanted to focus on as well to talk about the importance of a post-treatment biopsy in the management of patients treated with radiotherapy for localized prostate cancer. And while we have many imaging opportunities to assess the treatment response, there's nothing ultimately like a post-treatment biopsy, albeit there are limitations with its interpretation, but certainly it gives us greater understanding about the response and certainly could be enhanced along with that imaging as well. If we look back at the field, there's a lack of consensus on the optimal treatment for clinically localized prostate cancer, and it causes an incredible amount of confusion among patients because of the many treatment options that are available for them. Not only are there a multitude of options from surgery to different forms of radiotherapy, cryotherapy is out there, HIFU, laser ablative treatments, focal therapy as well, of course, active surveillance. And there's a scarcity, really, although there are trials, but a scarcity of head-on comparisons. Surgery to radiotherapy, we have the PROTECT trial. Looking at higher risk patients, we don't have that kind of information as far as a randomized trial. And so that ultimately leads to further confusion. Patients are often in the dark knowing what is the optimal therapy and which particular treatment is best for them. This results, of course, in a great deal of anxiety for patients regarding this uncertainty and what they really should be doing in terms of managing their disease. And especially when it comes to patients we treat with radiotherapy in the follow-up setting, there's also an increased amount of anxiety because the PSA levels are not going to go to undetectable. There's going to be a good deal of fluctuation in the follow-up period of time, and this again enhances the anxiety of patients. And furthermore, the challenges, particularly when it comes to prostate radiotherapy, is that there's a lack of an established biomarker to evaluate the radiosensitivity of prostate tumors routinely used, I would say. And we're certainly making progress in this area, but we don't have a PSA, quote unquote, marker that will tell us up front should these patients be responsive, these tumors responsive or not. And PSA relapse routinely is used to evaluate local tumor control after radiotherapy. Yet in patients with high-risk disease, we recognize that its value as a biomarker is uncertain for really evaluating the local residual disease status. It certainly is a reflection of possible micrometastases or local disease at the same time. And so we really don't have a good marker evaluating the efficacy of the localized therapy which we are delivering. We certainly have made a great deal of progress in terms of imaging with multiparametric MRI, but still, even with that, those approaches, it does not consistently allow us to discriminate between post-treatment inflammation, treated disease, or active residual disease. And even now, it gets even more complicated because within the radiotherapy domain, there are emerging new technologies in the delivery of high-dose radiation. We've moved from three-dimensional conformal radiotherapy to intensity-modulated radiation to image-guided radiation, and now there's a good deal of enthusiasm pushing towards moderate hypofractionated therapies where we are condensing the treatments down from 10 weeks to 5 weeks, and even ultra-hypofractionated treatments where these therapies are condensed even further from 5 weeks down to 1 week, or 5 fractions instead of 50 fractions. And the question really is, how do we compare these treatments to the established image-guided radiation of 10 weeks of therapy? And currently we don't have randomized trials making these kinds of comparisons, and thus the treatment related decisions which patients are forced to make when they are subjected to choose between the various local therapies is even more daunting. And so what I'd like to share with you this morning, as we get to talking about post-treatment biopsies, but to give you a background, would be to talk about the various radiotherapy interventions which are used in the treatment of clinically localized prostate cancer, to get a sense, at least from some of the retrospective comparisons that have been published, how does one approach compare to the other, and what would be the best endpoint in evaluating local tumor control to assess these local interventions, and what would be the endpoints to best evaluate disease eradication after radiotherapy. And then that will all be a segue into getting into a discussion of, is a post-treatment biopsy a valuable endpoint of assessing the efficacy of local radiotherapy, and what prognostic information does this provide to the clinician? So there are several important trials that have taught us that escalating the radiotherapy dose is a critical ingredient for achieving improved tumor control. And a number of retrospective studies, large institutional studies like ours, and subsequent randomized trials have clearly demonstrated that higher radiation dose levels are associated with improved PSA relapse-free survival outcomes at 10 years and longer. Improvements of 10 to 20% have been noted for low, intermediate, and selected high-risk patients when delivering these kinds of higher doses. An escalation of the dose has moved from 70 gray, which was thought to be the conventional dose, to now 80 gray, which is, I would say, considered the conventional radiation dose level to be employed for the management of localized prostate cancer. And these dose levels have not demonstrated any kind of a survival advantage to date as compared to hormonal therapy trials where survival advantages have been demonstrated. Moderate increases in toxicity have been observed from these studies with dose escalation, but fortunately we have emerging and established methods to reduce further the toxicity to the normal tissue structures. So here are the important dose escalation trials that have been published, number out there, 10-year outcome. They basically were comparing the high dose, 78 or 80 gray, down to 70 gray. And in each of these trials, there was about a 10 to 15% PSA relapse-free survival benefit at the 10-year point in general, with trials that were generally in the 300 to 600, 800 range of patients accrued. And once again, in these trials, it was observed that with, I guess, less sophisticated radiation techniques, as these studies generally use conventional 2D radiotherapy, not even three-dimensional radiation, as these studies were done in the early 90s. We observed higher rates of grade 3 urinary toxicity and some rectal toxicity as well, although not anything terribly significant or impactful for the patient in terms of very high numbers. We're generally talking about in the 10% range compared to lower doses. And so now that we have established with level 1 evidence that higher radiation dose levels were associated with improved PSA relapse-free survival outcomes, the next question that we had to ask ourselves is dose escalation accomplished with 80 gray sufficient for the eradication of localized prostate cancer? And are there more potent dose escalation regimens when using radiotherapy? And how can we more reliably reduce treatment-related side effects or toxicities when using dose-escalated radiotherapy if it appears that intensifying the dose is a critical ingredient for improving biochemical relapse-free survival? And so this is something that we've recently compiled, soon to publish, of 3,700 patients, probably the largest single institution compilation of patients who were treated to high dose levels. This is 81 gray or higher at our institution. And so it's excluding all of the lower dose treated patients. And what we observed for the low-risk patients, probably many of them didn't even need to be treated back then, but we were treating them then. 93% PSA relapse-free survival at 10 years, about 80% for the intermediate risk, and at 63% at 10 years for the high-risk patients, generally the higher Gleason scores, Gleason 8 to 10. And so even with high radiation dose levels, and generally these patients, the high-risk cohort, treated with hormonal therapy, we were still getting about a 60% PSA control. And the thought was that perhaps with even higher radiation dose levels, if this is a reflection, PSA relapse-free survival, a reflection of local tumor control or not, probably not in the high-risk group, but could we get better with higher radiation dose levels? Distant metastases-free survival for these risk groups shown here, 98 and 93% for the low and intermediate risk group, and still at 10 years there is certainly a clinical issue that needs to be reckoned with, and that's the incidence of distant metastases as expected in the high-risk group. These patients likely having micrometastases perhaps even before the radiation was even initiated. And so there have been many who have proposed utilizing various forms of, or alternative forms of dose escalation strategies compared to just what can be achieved with definitive external beam radiation, which could perhaps more effectively eradicate localized disease. And the thought is based on the biologic equivalent dose. These are theoretical estimates, but it's been proposed that patients, based on alpha-beta equations, patients who are treated with combinations of internal radiation or brachytherapy and external beam radiation compared to just these high radiation dose levels alone of 86 gray of external radiation, just based on those theoretical considerations, the application or combination of patients who were treated with brachytherapy in combination with external beam radiation seem to have, yes, a higher biologic equivalent dose, and this may translate into better outcomes at least. There have been actually suggestions as well that from the Mount Sinai experience where patients were actually undergoing post-treatment biopsies when they received combination of external beam and brachytherapy, that the incidence of post-treatment positive biopsy was actually low and less than 10%. And so when we've done retrospective comparisons between those patients who were treated with IMRT alone to as high as 86 gray versus combining the patients with external beam and brachytherapy for PSA relapse-free survival at about 8 years, we observed about a 10% difference in biochemical tumor control with the more intense dose regimen in intermediate risk disease. And for distant metastases-free survival, we also observed an improvement in distant metastases-free survival outcomes at 8 years between the group that had the dose-intensified regimen compared to external beam alone, and also borne out in a multivariate analysis. And this was, this concept, at least for intermediate, and actually in this important randomized trial, this was also about 2/3 of the patient were high risk and 1/3 was intermediate risk. And this was a randomized trial comparing dose escalation of 78 gray versus combination of external beam radiation plus the seed implant brachytherapy. And with about a 7-year follow-up, actually 9-year follow-up, the high risk and unfavorable intermediate risk, all of the patients in this study got 8 months of neoadjuvant hormonal therapy and 4 months of concurrent and adjuvant LHRH agonist therapy. And there was an improvement. They're only looking at PSA relapse-free survival, and I think it was only powered for that and not really for a survival benefit. But noticed so far an improvement in PSA relapse-free survival in the intermediate risk group and in the high-risk group as well. And when toxicity was looked at with this more intense dose regimen, there was a little bit higher, significantly higher, urinary-related toxicity, grade 2 urinary and grade 3 GU, in the group of patients who received the combination of external beam radiation and brachytherapy compared to the external beam radiation alone. Interestingly, these side effects are certainly higher than what we observe in our own experience and some others as well. Nevertheless, the take-home message here is that when it comes to intermediate and perhaps selected high-risk patients, dose escalation remains a critical ingredient in the management of the radiotherapeutic management of these patients. And it would appear that further enhancement of dose intensification, that is with the combination of brachytherapy and external beam radiation, may actually be a very potent regimen in treating such patients. Well, how do we reduce side effects? And what has emerged right now in the last 5 years has been really revolutionary in terms of our ability to target radiation much more effectively than ever before, reducing the volume of normal tissue structures exposed to these high dose levels that I've now discussed seem to be critical in the radiotherapeutic management of these patients. And so routinely now, patients are getting, prior to any therapy, fiducial markers placed in their prostate to act as, so to speak, bullseyes that we are targeting the daily treatment with accuracy of sub-millimeter. We're routinely now employing in our own institution to track the movement during the 3-minute radiation, and prostates do move based on respiratory motion. Filling of the bladder pushes the prostate, filling of the rectum as well. Even during the actual couple of minutes, gaseous distension can move the prostate during the actual treatment, and we're obviously sensitive to that. And so fortunately, we're able to track during the actual treatment now the prostate motion and make the appropriate corrections. And fortunately as well, we are now able to use MRI-based mapping and planning throughout the world. Radiotherapy is planned or mapped or delineated with CAT scan. We recognize in 2017 how critical MRI is in delineating the disease, and in particular delineating the dominant intraprostatic lesion, which certainly is the area and critical area that needs to be targeted. And with image guidance, we've seen less urinary-related side effects. This was one of the few comparisons that's out there, albeit just retrospective, looking at differences in urinary side effects between image-guided radiation versus not guiding it through imaging. And again, the side effects are expected to be related to probably a higher dose to the bladder, neck, or trigone. With the advent of MRI allowing us to delineate the target much more accurately, this is now what we contour off of instead of a CT scan. And what we're using right now is an FDA-approved hydrogel that's injected between the prostate and the rectum, creating a separation or a barrier, and obviously making it much easier to deliver these high doses with less concern of dose to the anterior wall of the rectum. And fortunately, this gel that's there dissolves after 4 to 6 months from its installation. And we've moved, and it's been a dramatic change in our own institution. It's been even surprising for me, but in the field itself, we've moved in a matter of years with the help of emergence of randomized trials and now institutional trials, still moving the field from 10-week course of treatment of 50 sessions almost, down to 25, as I mentioned, and even down to 5, which is now being studied. And these shorter radiation courses with higher doses per fraction may be more biologically advantageous for tumor control, and that's what's being studied right now. The randomized trials have demonstrated no significant differences in at least biochemical tumor control outcomes, PSA, relapse-free survival that is, with moderate hypofractionated regimens of 5 weeks compared to conventionally fractionated regimens. And here are 4 multi-center institutional trials which are very important, published, and basically, in particular the CHIP trial with over 3,000 patients, demonstrating pretty convincingly in all of these trials that the shorter course regimen does not demonstrate any inferior outcome compared to the classic traditional regimen of 10 weeks. And now many centers, radiation oncology centers throughout the country, are adopting the condensed forms of treatment as their new standard of care. And again, obviously more convenient for the patients in terms of just being treated for 4 or 5 weeks. There's also been certainly an increasing interest in ultra-hypofractionation, where we could move from 25 treatments down to 5 treatments. And single institutional experiences have utilized 5-fraction regimens delivered every other day with dose rangings from 35 to 40 gray, 5-year PSA relapse-free survivals, again for these low or intermediate risk groups. So these are patients who should generally do well, 90% with really very well tolerated treatment profile. And I'll be actually presenting in about a week at the ASTRO meeting our results of a phase 1 dose escalation trial, which is really never established in our field, the optimal dose per fraction for ultra-hypofractionated regimen. And to our surprise, when we looked at, as a secondary endpoint, post-treatment biopsies in this group of patients, as we moved the dose levels from 32.5 gray in 5 fractions to 35 to 37.5 to ultimately 40 gray, the CyberKnife world is really working in the 35 gray range. Interestingly, instead of 20 to 30% positive biopsies, we were seeing a 7% positive biopsy rate only in the 40 gray arm. There are 4 very important trials which are actually evaluating right now, endpoints only being PSA relapse-free survival, but here between either the moderate hypofractionated doses or the traditional conventionally fractionated doses versus these ultra hypofractionated regimens. So I'd say in another 4, 5, 7 years, we will have more and more information on ultra hypofractionated regimens, which is a dramatic revolutionary departure to what we were routinely using 5 years ago as 10 weeks of treatments. And hopefully these kinds of trials will give us more important information as to the efficacy of these shorter courses, and does it validate the hypothesis that lower or higher doses per fraction actually confers a biologic advantage for the patient in terms of local tumor control. And we can utilize these condensed regimens because of, as I mentioned, the available technology, which is either MRI-based treatment planning or more attention to the normal tissue structures, not just the bladder, but maybe the bladder neck or the urinary sphincter, or looking at the nerve bundles or the corporal tissues and penile bulb. We're certainly becoming more and more sophisticated as to the subanatomic components that may be associated with long-term toxicity. Our margins are much tighter than ever before, as we have the ability to see what we're treating and as accurate as we can. This rectal spacer that we're routinely using as a hydrogel may allow us to deliver these higher doses with less concern for rectal toxicity. So now the question becomes, are these improved outcomes reflecting enhance local tumor control, especially when we've seen combining brachytherapy and external beam radiation, which probably represent the tool that we have as radiation oncologists to deliver the greatest intensity of radiation dose level. And so I'd like to turn towards the post-treatment biopsy, and I'd say since the early 90s at Sloan Kettering, and other centers have done this as well, we have routinely at least tried, but there's been more of an effort certainly recently, but in our initial efforts of dose escalation with three-dimensional conformal radiotherapy, we tried to obtain biopsies at 2 to 3 years out from the radiotherapy. And as a number of pathologists have been very, have made important contributions in terms of the interpretation of the post-treatment biopsy, certainly not a simple thing to do. It's been now pretty well accepted that a positive biopsy is those tumor specimens that have gradable disease. The negative, of course, cannot be graded, or no adenocarcinoma at all. And then there's this middle-of-the-road gradation or category, adenocarcinoma with severe treatment effect, where a Gleason grade cannot be assigned. There's been some controversy as to what is a severe treatment effect. What does that connote clinically? Interestingly, when we looked at the group of patients that we treated with three-dimensional conformal IMRT, and we were able over the years to just look back, and there were selected patients only who underwent post-treatment biopsies at the 2 to 3 year point. Now we have in this group of patients about 15 to 20 year follow-up in these patients who underwent an early biopsy. And quite interestingly, when we look especially at those patients where we are, not quote-unquote contaminated with receiving any neoadjuvant hormonal therapy, and we're just looking at the patients who had radiotherapy to a median dose of 81 gray. For the intermediate, in particular the high risk, actually across the board, about 30 to close to 40% of the patients had positive treatment biopsies. Clearly, this is a select group of patients. It wasn't done in an ongoing fashion, but again, it's pretty telling that although some of these patients had PSA relapses, there were some that had pretty low PSAs that didn't achieve the definition of a PSA relapse, and still these patients were noted to have a positive biopsy. The overall incidence of a positive treatment biopsy, treatment effect and negative, was in this group of patients overall 25%, 21%, and 53% with a negative treatment biopsy. We also realized with this analysis that intermediate and high-risk patients who underwent ADT, just a short course of ADT, along with their external beam radiation, had, which was borderline significant, an improvement of the post-treatment biopsy outcome. It seemed to be thus a radiosensitizer to enhance tumor control, perhaps. We just didn't have enough patients to show it. But what I found very interesting, and there's a little bit of controversy associated with this, is what is the biologic significance of adenocarcinoma with severe treatment effect on a biopsy? And we previously reported that this biopsy category is histologically recognized and defined as residual tumor cells, poorly formed glands with abundant clear evacuated cytoplasm without evidence of mitotic figures, cannot be graded. The MD Anderson group have reported these biopsies behave as positive at about 3 to 5 year follow-up. And so we now have, fortunately, about 15 to 20 year follow-up in some of these patients. And I'd like to share that data with you now, and we're putting this together for publication. We looked at the group of patients, this is PSA relapse-free survival, and we plotted that out based on their biopsy status at the 2 to 3 year point. And very interestingly, the patients who had negative biopsies or treatment effects basically overlay each other compared to those patients with a positive biopsy. And so it appears, at least from the PSA relapse-free survival perspective, that the biologic behavior of a negative biopsy and a treatment effect biopsy are one and the same. And very interestingly, the distant metastases-free survival seems to be overlaid as well, compared with negative and treatment effect compared to a positive biopsy. And when we looked at a time-dependent survival analysis for distant metastases, positive versus negative in this multivariate analysis, highly significant. When we look at treatment effect versus negative, there's really no difference. And again, positive versus a treatment effect, significantly different. So the treatment effect and the negative are really behaving long-term, or the treatment effect is really behaving like a negative biopsy. And I'd like to conclude basically with a direction that we're trying to use with all of our high-risk patients in terms of the quest to try to better understand, even before we administer radiotherapy, can we identify the radio responsive genotype that would allow us to predict for radiotherapy response and maybe give us greater ability to select the patient with high-risk disease for one therapy or another. And we recognize that there's an extraordinary heterogeneity in the response of radiotherapy, specifically within high-risk disease, which is, of course, defined as Gleason 8 to 10, high PSA, and high T stage. I showed you before that with 81 gray or higher, 60% of patients had at 10 years of PSA relapse-free survival benefit, but 40% of these patients are either failing locally, we've seen that based on the biopsy, or failing distantly. And when we look at AR transcriptional activity or DNA repair gene expression across even primary prostate tumors, there's a great deal of heterogeneity. And the DNA damage repair mutations certainly have an influence we've seen on the primary prostate cancer. It's been studied, of course, very well in the metastatic setting. But there's a substantial portion of patients with primary disease who harbor somatic and or germline genetic alterations in DNA repair. And small subset of patients with prostate cancer harbor germline defects in BRCA2. And so with high throughput genomic profiling, and we're doing a lot of that at our institution, we're really trying to identify even these patients at earlier stages, high-risk disease, to identify deleterious genetic alterations in a more diverse set of DNA repair genes than have been used, including what I show here, to really try to identify which are the patients that may respond to radiotherapy or may be better candidates for surgery, which remains a very controversial area in the field of genitourinary oncology. And we have observed that there is an enrichment of repair alterations with patients with higher Gleason scores, and this is taken from the TCGA, in primary prostate cancer. And here in Gleason 9 to 10, looking at the percentage of patients with DNA damage repair alterations, you could see that kind of correlation as expected in the higher risk patients. And when we looked at disease-free survival based on the presence of DNA damage repair alterations, we observed a significant difference in disease-free survival. So some of our thrust in terms of current research would be the hypothesis is that germline and or somatic defects in DNA repair will predict for response to radiotherapy, and we're really actively pursuing this now. And a combination with synergistic efficacy has been shown to be mediated by the induction of DNA damage and impairment of DNA repair. And hopefully, we can identify in the future genomic predictors of radiation resistance in high-risk patients in order to select out those who are more likely to benefit from radical prostatectomy or those that potentially, if they would respond, would do well with radiotherapy combined with hormonal therapy or some targeted therapy as well. And that leads to what was alluded to before, which is a really exciting direction, and that is using PARP inhibitors even at earlier stages than what has been already shown in castrate-resistant disease. And preclinical data suggests that the inactivation of homologous DNA repair results in tumor-specific sensitivity to combining radiation and PARP inhibition. And so we're pushing towards a phase 1 study in specifically high-risk patients who have DNA damage repair mutations to evaluate PARP inhibition as a radiosensitizing strategy for primary prostate cancer, and based on post-treatment biopsies to evaluate, get the tissue, again, to determine eligibility, and post-treatment evaluations at 6-month biopsies and at 24 months biopsies as well. And with correlative translational studies to look at these post-treatment biopsies with the goal of identifying the acquired mechanisms of resistance to combine PARP inhibition and radiotherapy. I think we're moving into extraordinary, exciting avenues of research now, trying to a more tailored or personalized medicine in high-risk disease in the primary setting as well, to really select out who are the patients that should respond to radiotherapy and who should avoid radiotherapy for the time being, based on the presence of DNA damage repair mutations or alterations. So here are my conclusions. We've talked about today some of the exciting developments in radiotherapy in the treatment of clinically localized disease. We've made revolutionary changes over the last 20, 30 years. And so the comparisons that are made from studies that have been even 15 years ago, it's unfortunately a moving target. It's hard to make those comparisons, but that's what's happening, and fortunately for our patients as well, in terms of moving from 3D conformal radiotherapy, IMRT, image-guided radiation, hypofractionated radiation, and stereotactic radiosurgery, as we've talked about. We've learned along the way that higher radiation dose levels are a critical ingredient for success, of course, along with hormonal therapy in the high-risk group. And we also talked about the importance of using, in addition, and maybe more importantly than PSA relapse-free survival, to consider more often a post-radiotherapy biopsy to assess for the efficacy of the local intervention. We talked about the interpretation of a post-treatment biopsy as well, and the significance of treatment effect. And I think now, which is perhaps the most exciting areas of investigation in clinical radiotherapy in prostate cancer, is looking at genomic profiling to identify these genetic alterations that may predict for radio responsiveness, and hopefully in the future use targeted therapies to modify that response to improve the outcomes in these high-risk patients. Thank you very much for your attention.